Hello, and welcome to my presentation on disease pathology, post-traumatic stress disorder, or PTSD. Thank you for checking this presentation out. I am Amanda Hawes, a senior psychology major at UMGC, and I will be your presenter. So first off, what is PTSD? To state this simply, PTSD is a chronic maladaptive response to a real or perceived threat. It's incredibly important to take note of the perceived trauma portion. So you could say the development of this disease is very intimate to the way a person internalizes and characterizes events that happen in their lives. A unique aspect of this disease is that there is a defined starting point, which is the perception of the traumatic experience. Unlike other disease pathologies, it's fairly reasonable to assume PTSD progresses after traumatic exposure. So there are cognitive, behavioral, and physiological symptoms of PTSD. 60% of American men and 50% of American women will experience a traumatic event in their life. Only 6% will develop PTSD. So the changes in cognition include processes such as memory and attention. Behavioral changes include avoidance, aggression, negative mood, nightmares, and alertness. There's also a multiple physiological changes that occur, such as increased heart rate, sleep issues, fatigue, chronic pain. These symptoms can range from moderate to severe, in some cases be extremely debilitating. What are the impacts on the individual's lifestyle and society? It helps to understand the disease behind these economic and social challenges. At the core of PTSD, the individual experiences issues with trust, closeness, avoidance, and pleasure. Comorbidities may arise, such as substance use or depression. Among these populations, there's an increase in unemployment, which leads to food and housing insecurity. Additionally, the cost to treat PTSD is estimated at about $17,000 to $25,000 per person. The individual also experiences loss in closeness to family members, friends, coworkers, and employers. So the HPA axis is a complex hormonal system that works with the sympathetic nervous system to regulate the body's response to stressful stimuli, including regulation of the fight or flight response. Ordinarily, when a stressful experience is encountered, the hypothalamus releases CRH, which signals the pituitary gland to release ACTH. ACTH then signals the adrenal glands to release cortisol, which helps the body cope with stress. Additionally, the hippocampus plays a significant role in regulating the HPA axis. The hippocampus acts as a negative feedback regulator by signaling inhibition of the release of corticosteroids. This response prepares the body for action following exposure to a stressful stimuli. In cases of chronic or prolonged stress, the HPA axis becomes dysregulated. The specific mechanisms that lead to PTSD aren't clearly understood. However, there's hormones that have been identified as playing a major role. Specifically, there will be lower or higher than normal cortisol levels. The alteration in cortisol levels has major repercussions in memory consolidation and emotional regulation. So that results in intrusive memories, flashbacks, and increased emotional reactivity. So in PTSD, we do see abnormal regulation of these systems. Due to the hippocampus's involvement in the HPA axis, we do see a reduction in hippocampal volume from heightened exposure to hormones. Additionally, changes in neurocircuitry involving stress coding and fear processing, anxiety increases, and changes in ACTH response are observed. Specific areas in the brain experience anatomical changes. The amygdala is the region of the brain responsible for processing emotions such as fear and anger. Activity increases in this area, which leads to hypervigilance and impairment in discriminating threats, or increased volatility in regulating fear and anger. The hippocampus is significantly impacted by the disease progression of PTSD. Hippocampal volume experiences atrophy and synaptic plasticity is reduced. Thereby, it impacts the role of negative feedback regulator. Additionally, memory retrieval becomes impaired and cognitive dysfunction becomes apparent. Other regions experience reduction in volume, including prefrontal cortex and anterior cingulate. This results in dysfunctional decision-making and impairment of extinction of fear responses. There's also an observance of neurotransmitter imbalances. This includes serotonin. Decreased concentrations lead to heightened anxiety. The family of catecholamines include dopamine and norepinephrine. So dopamine generates a change in fear conditioning, so an association may be made that the person can't let go of. And increased norepinephrine heightens fearful memories. And there's also adverse physiological symptoms. Amino acids such as GABA and glutamate, they play important roles in inhibitory process, and glutamate plays a role in excitatory process. So GABA is decreased and anxiety goes up, and increased glutamate leads to symptoms of dissociation. Neuropeptide Y is decreased, so ultimately an upregulation to stress is observed and opioid receptors are altered. So who's at risk for developing PTSD? The answer is everyone, specifically anyone who experienced a traumatic event such as sexual assault, combat, catastrophic environmental event, the list goes on. However, some populations are more susceptible to developing this disease. Women are twice as likely to develop PTSD as men. Children, they have lowered autonomy and decision-making capabilities. They're more susceptible than adults. And then also occupation. So so with occupation, we see an increased chance of exposure, which also increases the risk of PTSD developing. So there are measures that can be taken to completely prevent or decrease the progression of this disease. Some of these measures include more experimental approaches with medication that are still being evaluated. For example, hydrocortisone in post-traumatic, used as an intervention in post-traumatic, results in increase in synaptic plasticity and connectivity. And then there's non-medicinal approaches to prevention, including debriefing at traumatic events, which commonly occurs in the healthcare setting, and cognitive behavioral therapy. So how is PTSD diagnosed? So PTSD is diagnosed by a trained clinical psychologist or psychiatrist through the use of the DSM-5 and a combination of self-reports and interviews. The type of interview that is provided to the patient depends on time availability and patient-reported symptoms. Two types of common interviews are the SIP and the SCID PTSD model. Of course, the SCID PTSD model is much longer and in-depth than the SIP. Self-reports include the PCL-5 and PSSR. The PCL-5 is good for rolling in or rolling out PTSD, and the PSSR can be used routinely to measure the severity of symptoms. Ultimately, the DSM-5 is the manual the trained professional will use to diagnose PTSD. Specific criteria must be met to diagnose disorder. Each category specifies how many, so in criterion A, B, C, one of these symptoms must be present. Criterion D dictates that two of these mood symptoms must be present, such as anhedonia, negative affect, or exaggerated blame. These symptoms must persist for longer than a month. Additionally, there must be a social or occupational impairment, and the diagnosis excludes the possibility of medications or other illnesses being the reason for the presence of the symptoms. There's also must be a presence of dissociative or delayed specifications. Dissociative specifications may involve depersonalization or out-of-body experience. This is like a detachment as if in a dream state. Derealization presents as a person questioning reality, also known as reality testing. Delayed specification is when all criteria are met at 6 months after the trauma. Treatment for this disease involves various therapeutic approaches such as cognitive behavioral therapy, cognitive processing therapy, prolonged exposure, and EMDR. Prescription medications such as SSRIs may also be prescribed. A combination of these therapeutic approaches may be used, which is dependent on the individual symptom severity. So this concludes my presentation. Thank you for watching, and I hope you found this informative.